So we're going to look at some common eye disorders and just go over a few of the slides in chapter 35. I wanted to point out to make sure that with all well child exams, we're getting some sort of history on vision assessment, as well as doing including physical exam of the eyes. And American Academy of Pediatrics recommends anything after 3 months of age, any kind of abnormalities with being able to follow and track, to be referred to ophthalmology. So we want to make sure that we're asking the caregivers about the infant's ability to focus on their face and track track objects, and document that in the chart as well. So a really common question is when to expect normal eye growth or fully developed eyes in children, and between 10 to 13 years of age, usually those pathways have completed growing, and we have the full size and visual acuity of the eyes at that time. Usually by age 10, whatever their adult visual acuity is going to be established at that time. So we want to make sure that before that age, though, that we're not missing any kind of ophthalmic issues like strabismus or amblyopia, because we can have some irreversible damage, and it's really difficult to treat once the muscles become fixed with some of the ocular disorders. So early referral is really important. So I would just kind of review some of the most common issues in eye disorders in children. Certainly strabismus and amblyopia are very common. Retinopathy of prematurity we see predominantly in low birth weight infants and infants that required excessive oxygen during the early neonatal period, and those should any of those disorders should be referred and then followed by optometry or ophthalmology as scheduled. So when you're doing your physical exam, just make sure that you're looking carefully at the eyes, looking for any kind of discharge, always checking the red reflex, super important, especially in infants and young children. When we see retinoblastoma developing after 5 years of age, usually you're able to actually change your otoscope tip to your ophthalmoscope and actually take a look at the fundus and do a funduscopic exam. You want to make sure that you turn the lights off and try to keep the child still while you do that. And then I also wanted to point out that in African American or some darker skinned ethnicities, sometimes the red reflex does appear kind of silver, but so you kind of have to get used to looking at that. Any asymmetry, any type of malalignment when you're looking at the eyes and doing the corneal light reflex needs to be referred as well. So this point here, family history of any ophthalmic issues, retinoblastoma should be sent for ophthalmic exam like really early on in infancy. So the two main types in primary care of screening tests you'll be doing are visual acuity and really based on child's developmental level, whether they're able to use like the Snellen eye chart with letters if they know their alphabet, or if they need to do the shapes and symbols one. So also the child needs to be compliant and able to sit still and focus. And so sometimes it's hard to do that before age 4. But you just kind of do the best you can. With younger children, you can ask if they are able to see airplanes in the sky and birds and flying, and if they're able to see small objects and pick them up. Um, and by parent report, you're usually able to tell just a very gross vision screen that way. Um, Also, make sure that we are checking that the pupils are equal and that the corneal light reflex is even. That's one of the easiest ways to tell if there's any abnormality in alignment. A lot of times, children will have pseudostrabismus, so just kind of a wider nasal bridge, and so it looks like that one eye might be deviating some. But when you do the corneal light reflex and hold your otoscope just kind of directly in front of their face, you'll see that the light is shining back at you at the exact same spot in the eye. So that's the best way to tell the difference between strabismus and pseudostrabismus. And pseudostrabismus is not a problem at all. That's just the way that the child is made. So I wanted to point out also in clinical settings, if you've not done a fluorescein stain, that is one procedure that you would want to become familiar with. There's also good just little training videos. And basically, if a child scratches their eye, their cornea, or is having like watering and tearing and pain, then we can do a fluorescein stain to see the extent of corneal damage. And if there is a corneal abrasion, then, based on the severity, the treatment will kind of come from there. So I wanted to look at management strategies. And just for some of these common issues, the main thing is to know kind of when to refer. Ophthalmology is really for eye pathology. But if it's just vision issues, refractive errors, and then we need, just more of an acuity issue, need glasses, optometry can take care of that. Often children with strabismus will need to have a chemical patch or wear glasses, certain special glasses from the ophthalmologist in order to improve the strabismus and prevent, like I said earlier, the permanent damage that can occur. So I wanted to point out with eye drops and ophthalmic medications, I think we've talked before that you can use eye drops in the ears, but not ear drops in the eyes for most things. So I did want to kind of point out, children have different pharmacokinetics and faster metabolism, and so putting medication into the eyes can kind of affect children differently than adults, and so we want to make sure we're using those as prescribed. I've also talked before about not using fluoroquinolones in children, and children under 18. They're not approved, so except for eye drops, ear drops, and so a lot of the topical antibiotics that we'll use for bacterial conjunctivitis will have fluoroquinolones in them. Also, drops with sulfacetamide or trimethoprim, polymyxin B. You can just kind of choose based on patient's insurance or affordability, and unless there's resistant patterns of kind of in the area that you're practicing. So ointments are preferred in children. It's just easier to kind of put a line of ointment in and make sure that you've gotten it in. It also, when they blink, it will disperse the ointment, and usually they don't sting. So you just want to make sure that you don't touch the tip of the tube to the eye itself, and just pull the lower canthus down, put a very thin line of ointment in, and as they blink, that will disperse. And also the ointments are soothing, and so if a child has some irritation, the ointment is going to help with that as well. You have to be pretty careful with steroids in the eyes. As in primary care, we don't usually prescribe that. So you'll see children coming on medications maybe to your office with prescribed steroids from the ophthalmologist. But again, there can be significant side effects from steroids. So this is not something that we would frequently or that we would prescribe as PMPs. Other medications would just be like ophthalmic antihistamines, like such as Patanol, mast cell stabilizers. This would be like cromolyn sodium or some eye drops, and a lot of these are over the counter as well. And then Visine is an actual decongestant, so it's a vasoconstriction, and that's vasoconstrictor, and that kind of gets rid of the redness in um, in the conjunctiva. So those are probably the most common medications that you'll be prescribing for eyes. So I want to talk real quick about trauma. Kids are very courageous and can definitely wreak havoc on themselves with trauma from injuries. So most of the time, eye injuries are sports related, especially when it's balls and bats, and we want to make sure that children are wearing and adolescents are wearing protective eyewear if that's indicated in whatever sport that they're participating in. And then also just making sure, especially now as common as computer and screen uses and cell phones, just make sure that we're not overstraining the eyes or getting any kind of damage from frequent electronic use. So that's part of the history that you'll be getting, kind of how much screen time children are getting. So there's really not much as far as dyslexia. In the past, they've done different types of therapies and things like that, but there's really not been enough treatment evidence to have that as a normal recommended treatment. So just a few comments about amblyopia. So amblyopia is one unilateral deficit with a defect in the vision. And so what happens, we normally will, a lot of times we'll kind of switch out or use the names interchangeably between strabismus and amblyopia. But if you look here, just kind of will help you remember, strabismus is kind of a type of amblyopia. And so amblyopia is kind of a general defect. And so it can be kind of like more fixed, or it can be like a drifting eye. So strabismus is just kind of like quote unquote lazy eye. And again, that's a type of amblyopia, which is just meaning one eye with a visual impact on the vision. And so with that disorder, the child is not getting clear images all the way to the brain, and so it can cause reduced or permanent vision loss. So what do we do about that? We send them definitely to the optometrist. Depending on the severity, they may have to go to the ophthalmologist, but they'll definitely need to go and have vision checks. So definitely just kind of refer them on if that's picked up. And so with strabismus, just the word in general means a defect in ocular alignment, and we talked about amblyopia being strabismus kind of if it's on one eye, but both eyes can actually be crossed. And so that can be like esotropia or exotropia. I did want to point out that in kids that are 6 months of age until 4 years of age, when they're tired, it's not uncommon for one eye to kind of drift outward. And it's usually, like I said, when they're tired. So, you want to kind of just see if that is if it's outside of those age parameters, or if it's something that becomes problematic or very recurrent, then that needs to be referred as well. And then another common issue is nystagmus, and this is just kind of jerking or rhythmic movements of the eye, and they can be different directions, and really we just need to refer that on as well. That's not, even though it's kind of common, you want to just see what effect that is having on their vision. And then again, retinopathy of prematurity, you may have low birth weight infants that you're following up in the clinic. And so it is definitely within your scope and responsibility to make sure that they are following up with the ophthalmologist and kind of make sure that their vision is developing as normal. So normally they will see the pediatric ophthalmologist in the neonatal intensive care, and that's when the retinopathy prematurity should be picked up on. And what they'll see with this, the clinical findings are kind of a haziness to the vitreous humor, hemorrhage, retinal and iris changes, some strabismus, cataracts. So there's all kinds of different clinical findings that can occur based on the severity of the retinopathy or prematurity. And the last bullet on this slide, just refer for intervention services for children that have visual issues. So they'll be seeing the ophthalmologist, but you would want to refer them kind of immediately if they have decreased vision acuity. A lot of times it's going to be so severe that even corrective lenses once they get older may not fix that. So you're going to want to set them up with early intervention as an infant for further screening. Complications can be severe, and so this can definitely lead to long-term visual issues, and depending on how well it's managed early on and early intervention, the child can hopefully learn to have some accommodation and be successful in school and later on in life, and as long as we can get visual acuity taken care of. And then I also just wanted to point out conjunctivitis in the newborn. Always remember that if we're within the first 2 weeks of life, then we really want to treat those infections, those gunky eyes, as we want to cover for any kind of bacteria that could have been picked up when the infant's coming through the vaginal canal. So we want to make sure that we're covering for chlamydia, which is the most common of ophthalmia neonatorum or neonatal conjunctivitis, and also covering for chlamydia and for gonorrhea. So you'll want to swab and make sure. So under 2 weeks of age, don't just kind of treat that goopy eye. You want to go ahead and swab, and then make sure that hopefully it's just a non-GYN or non-STI bacteria, and however, if so, then that needs to be handled more aggressively. So if it is a gonococcal, then they will need IM Rocephin. Otherwise, they can usually topical antibiotics will cover, but it needs to be documented and follow up. And if they have a chlamydial conjunctivitis, then you need to be concerned that they could have chlamydial pneumonia or some of the other sequelae that come along with that. So bacterial conjunctivitis, normally you don't have to culture this in older children. You kind of get used to just seeing what pink eye, quote unquote, looks like, red injected conjunctiva with purulent drainage, and usually there'll be a report of the child waking up with their eyes kind of matted shut. So topical antibiotics can be used, and we talked about which ointments to use for conjunctivitis. I do want to point out, it's a common test question as well. If it is, if we have a conjunctivitis that is going along with otitis media, then it is usually caused by H. flu. So we want to make sure that we treat those with a with an antibiotic, treat that ears with an antibiotic that is going to cover H. flu. Um, so we'll want to make sure that we're using something that has a beta-lactam antibiotic in it. So augmentin or one of the cephalosporins that cover for beta-lactams. And viral conjunctivitis is really just those red, injected, watery eyes. Sometimes you'll see a little bit of purulent drainage, but normally this is like the red, clear watery discharge that you see if you picture someone kind of with a cold and their eyes kind of draining. So sometimes it's hard to tell if it's viral or bacterial, but usually those are going along with a viral syndrome. And that's all I wanted to talk about on those slides. Other than, let me mention quickly, periorbital cellulitis. We had some comments on this with sinusitis, knowing that your sinuses are just kind of a hole in your head. We can get infection from like untreated or partially treated sinus infections that bacteria can kind of spread, and we can get periorbital cellulitis from bacteria. So that's also if we have a severe kind of conjunctivitis or something that's not that can spread to that as well. So depending on the extent of the cellulitis will determine kind of how we manage this. So if it's mild and the orbit is not involved and they're not systemically sick with fever and other symptoms, and they're over 1 year of age, you can usually do oral antibiotics. However, with moderate to severe periorbital cellulitis, you do need to admit them because they really will need IV antibiotics to be able to penetrate that bony orifice and get good antibiotic coverage to the orbits there. Just like with sinuses, it's just hard to treat those bony orbits. And that's it on these slides for eye disorders.